There are three speakers this morning who I've been involved actually with their training, which makes me feel kind of old, but kind of delighted that now they're employing me and I'm working with them. The first is James Ennis, currently clinical lead at the University of Chester, who I believe has put together a presentation, a stat review of his work with ACEs alongside other methods of simulation. Good morning, James. Good afternoon, James.
Good afternoon, Mark. Thank you.
I will let
Can you
you
hear me
take the
okay?
podium. Okay, you good to go?
Yeah, thanks, Mark.
Thank you.
And thanks, Bob and Matt, for having me. So I hope you can see the slides?
Yeah, you need to switch to slideshow.
Sorry, it's on my other screen. Okay, all right.
That's it.
So thanks for having me. I'll give you a quick introduction to who I am. So I'm a physician associate by background, and I've worked with ACEs. I've worked it out for just over 10 years now. I've also had training from associate clinical educators, so I've seen it from both perspectives, as an educator and as a student. So I'm just going to quickly give you an overview of how we use associate clinical educators at Chester. Now, it's quite a new concept to Chester. I've recently moved from Birmingham up to Chester and brought the associate clinical educator role up with me. And this is a picture of our team. So I'm going to talk about how we use them, where we use them. I'm going to give you some quotes on our student experience and our most recent student feedback on the curriculum, on the course, on more importantly, simulation and the ACEs themselves. I'm going to try and give you a balanced opinion on it, because there are some perceived threats, in my opinion, and also then the future development within research. So as Jim mentioned, we've got a strong emphasis on high fidelity with regard to human simulation at Chester. We use ACEs as simulated or standardized patients, typically in role play, and that's both in teaching and assessment. The difference obviously between the ACE and the simulated patient, which people are probably far more familiar with, is that they can give this feedback on physical examination skills. Now, we've kind of gone away from the compartmentalization of history taking, physical examination skills, and looked at it more as a kind of an integrated model, which is how clinicians truly consult. As well as that, we use the ACEs in specialist roles for intimate examinations. We use the breast teaching associates, again, both in teaching and assessment, as well as the male teaching associates. We're still yet to fully establish the gynecological teaching associates, but that's something that I'm working on for 2022. And we also use them in a hybrid approach. So again, as Jim mentioned, with regard to the what we would typically think of with regard to high fidelity is the all singing, all dancing sim mannequins. Yes, of course, we do use them as well, particularly in emergency scenarios, but we also use the ACEs as part of a role play so that the communication, again, isn't lost. Again, looking at that integrated model. So where do we use them? This has obviously recently changed, as I'm sure it has for most educationalists during the pandemic. We found that ACE use has become particularly useful, or simulated patient use, in replicating current practice with online consultations. And we vary this, again, we think it's useful when a online consultation would be appropriate for a medication review, perhaps, but not if they've got an acute abdomen or suspected acute abdomen, obviously, because they'd be presenting directly to ED. So we try to make this direct relationship correlation with clinical practice. And obviously we're using ACEs primarily in the simulation labs, again, like I say, for consultation skills, teaching and learning. the student experience. So I've captured a few of our most recent student staff liaison minutes and meetings. And these are from our year 2 students. These are kind of common themes. So I've just picked a few just to quickly touch on. I think almost looking at it completely comprehensively of positive feedback from students on the ACE role and what they give. They find it far less threatening to make mistakes when performing physical examinations and technique refinement. As you can see, the first one says they're completely invaluable. However, I would like to mention there that it does say that mannequins and other types of simulation may be just as helpful. Now, what I would say is I don't see the ACE role completely dominating simulation in medical education. It's very much as an adjunct, and that's how we utilize our ACEs. The students obviously get quite twitchy around OSCEs and assessment methods. And again, we found ACEs incredibly helpful, not just for improving students' technique and examination skills, but also their confidence going into things like OSCEs and ISCEs and clinical examinations. Great thing with the ACE teams as well, there's different backgrounds. Some have actual pathologies. Some come from a diverse background, and that's something obviously that our students appreciate. And this real life application, as again Jim mentioned. Finally, they really responded positively to the ACE role in working on things that they find specifically difficult. And one of the things that I've highlighted there is the MSK examination. So it's one thing that our ACEs really cover in depth with our students. Something that they find difficult, and something that our ACEs are heavily trained in, as I'm sure Uzo will talk about far greater depth than I can. And like I say, with regard to the COVID restrictions, what we found is obviously we've lost some time, and the ACEs have been great in building the student confidence and time in simulation to get them to a point where we're happy for clinical practice and patient safety ultimately is why we're really so keen, obviously, all on simulation. So for perceived threats, I'm sure most of you who haven't used ACEs or simulated patients in any great detail will find that they've had some pushback from their institutes around the financial burden. I mean, the way we've worked around this is I would far prefer to have the human factor, the human input in simulation than buy perhaps an £80,000 sim man. Yes, I mean they do have their place, but I would prefer to instead of buying several of them, I'd rather put our money towards ACEs. And there are ways around this. I found I've certainly not had any problems from my institute with getting the financial buying, shall we say, especially when you're getting such feedback from students. One thing that we haven't got a great amount of evidence on is the student and patient outcome from such interventions. And that's something I'll come on to later when I'm looking at my research. The ACE training, again, we need to invest in that as clinicians and as educationalists. And one concern we have is just our geographical area. They're more based in the Midlands, but we would love to have our own and growing banks in Cheshire and the surrounding area. So another two things just quickly, clinician resource. ACEs are not substitutes for clinicians. They give a very specific and very constructive level of feedback. But you do need to be mindful that the clinician should be there to cover any clinical areas or questions. And then again, then ACE regulation recognition needs improvement and development, especially when we're looking at using these trained lay people in intimate areas such as gynecology and male genitalia exams, for example. And then finally, that's just a quick overview of where I'm going with my research, and I would invite anybody to contact me if they're interested in it. We're looking at, like I say, the ACEs and particularly the impact of student performance and therefore patient outcome. You know, if we're training via this modality, what effect is it having on student competency and therefore student performance as qualified clinicians, and therefore patient outcomes and safety? The use of haptics, which is to give kind of tactile feedback in skill acquisition. And then again, developing further the hybrid approaches, so the uses of sims and the more traditional higher fidelity areas. All right, I think that's me, Mark.